Bismillahirrahmanirrahim. My name is Dr Muzzamil. I am from Medical Unit 5. Today we will discuss about multiple endocrine neoplasm syndromes and also about the polyglandular disease. Somehow a bit boring, but kindly be patient and listen up to the end of the lecture. I will try to highlight important points at the same time. So coming to the next slide. So multiple endocrine neoplasia syndromes consist of two categories, type 1 and type 2. Type 2 is further has been divided into 2A and 2B. And there is also a type which is called medullary thyroid cancer, MTC only. We will highlight in our lecture about type 1 and type 2 mainly. So this is somehow a slide, very important slide, just to have a few formulas so that you can remember easily what are the diseases included in type 1 and what are included in type 2A and 2B. Talking about men type 1, we have a formula called 3 P's: parathyroid hyperplasia, pituitary tumors, and pancreatic islet cell tumors. Talking about men 2 type 2A, we have a formula 2 P's 1M, and P for parathyroid hyperplasia, same as in men type 1. Then there is a pheochromocytoma and medullary thyroid cancer. And in 2B, it will be included what is in marfanite habitus and mucosal neuromas, along with pheochromocytoma and medullary thyroid cancer, which are also present in men type 2A. So here is 2M1P. So it is easy to remember. Talking about type 1, the combination of parathyroid tumors, pancreatic islet cell tumors, and anterior pituitary tumors is characteristic of men 1, as we have discussed in the last slide. It is usually inherited as an autosomal dominant disorder. It can also occur sporadically without a family history. In 1954, Wormer was the first to describe this syndrome. Therefore, it is also called as Wormer syndrome as well. So in this slide, it is the prevalence and the distribution, and the most common to least common. It has been enumerated in detail. So this graph predicts very well which is most common is the parathyroid tumor, then gastroma, then insulinoma, and then at lastly prolactinoma. The responsible gene for MEN1 is located at 11q13 and codes for the menin protein. Menin is involved with regulation of transcription and genome stability. Loss of heterozygosity for this region is associated with MEN1, suggesting that the gene has tumor suppression function. It is autosomal dominant disorder, but sporadic mutations also occur. Number 1 is the parathyroid tumors. Parathyroid is a primary hyperparathyroidism caused by hyperplasia of parathyroid gland. It is the most common manifestation of multiple endocrine neoplasm type 1 and occurs in approximately 90% of all patients. Clinically, manifestations can include hypercalcemia, nephrolithiasis, and bone abnormalities, osteitis fibrosa cystica. Common symptoms associated with hypercalcemia include polydipsia, polyuria, constipation, and generalized malaise. Pancreatic islet cell tumors, these are also called neuroendocrine tumors, is the second most common at 30 to 80% of men 1. Islet cell tumors more encompass gastrinomas, insulinomas, glucagonomas, vasoactive intestinal peptides, vipomas, and pancreatic polypeptidomas, PPOMas. Often multicentric and may undergo malignant transformation, and these tumors can produce peptides and biogenic amines. However, non-functioning pancreatic endocrine tumors are the most common enteropancreatic neuroendocrine tumors. Important to diagnose, as malignant pancreatic neuroendocrine tumors are the most frequent cause of death in people with MEN1. So it could be an important MCQ as well. Now talking about gastrinomas, the most common functional pancreatic neuroendocrine tumors, often small, multicentering and located in the duodenum, thus diminishing the probability of surgical cure. The features predictive of poor prognosis include pancreatic location of lesions, metastasis, ectopic Cushing syndrome, and high gastrin levels. The development of gastrinomas is preceded by multifocal hyperplasia of the gastrin producing cells. Second comes insulinomas. Can be multicentric and can metastasize either to regional lymph nodes or to the liver. Unlike non-MEN1, insulinomas usually occurs in the patients younger than 40 years and many are diagnosed in patients younger than 20 years. Patients often present with hypoglycemic symptoms after a fast low blood glucose with symptoms improving after glucose intake. Hypoglycemic symptoms, which is also called as Whipple's triad, is usually been used in the wards. Thirdly comes glucogonomas. Is a rare 3% in patients with MEN1, can present silently or with hyperglycemia. Few patients show the typical skin lesions known as necrolytic migratory erythemas. We will show you the pictures in the next slides. Others presenting symptoms can be anemia, stomatitis, weight loss, but these are often absent. You see necrolytic migratory erythema on the face, on the lower abdomen, perineum, lower extremity. Then vipomas, tumor secreting pancreatic polypeptides, and growth hormone releasing hormone tumors. Coming to the pituitary tumors, MEN1 associated pituitary tumors most commonly secrete prolactin, followed by tumors that secrete growth hormone. Less than 5% secrete corticotropin and others are non-functional. Compared with non-MEN1 pituitary tumors, they tend to be larger, which is called macroadenomas, and more aggressive, with a higher rate of infiltration of tumor cells into the normal pituitary tissues. MEN1 associated pituitary tumors are less responsive to therapy. However, there is no distinct histological differences between MEN1 and non-MEN1 pituitary tumors. Other tumors associated with MEN1 are carcinoid tumors. Cutaneous expression of MEN1 is common. Then comes the adrenal tumors, thyroid adenomas, and meningiomas. Regarding carcinoid tumors, can occur in patients with MEN1 and are located in the bronchi, gastrointestinal tract, pancreas, and thymus. Carcinoids can actively secrete hormones such as serotonin, somatostatin, corticotropin, and growth hormone. Cutaneous expression can be facial angiofibromas, cholangiomas may be present. And adrenal tumors occurs and usually are non-functioning and they're most often benign tumors in 20 to 40% of the patients. Talking about thyroid adenomas, occurs in 5 to 30% of patients and have a non-specific MEN1 reported clinically significant. Laboratory studies. To pick up gastrinomas, screening should be started by age 20 years, and the diagnosis of gastrinoma is confirmed by a basal serum gastrin level more than 1000 picogram per ml. And you have to switch off proton pump inhibitors before doing this test because it interferes with the gastrin levels. A basal gastrin levels more than 250 is suggestive and can be confirmed with the secretion stimulation test. Then insulinomas, yes, a supervised 72 hours fast is used most often to confirm this diagnosis. And the screening should be started by the age of 5 years. Glucogonomas, elevated serum glucagon levels and hyperglycemia. Then vasoactive intestinal polypeptides, vipomas, elevated serum levels of VIP, are present. Then comes the pancreatic polypeptidomas. Here again you will pick up the pancreatic polypeptide levels. Then carcinoid tumors. Here you will go for elevated levels of chromogranin A, calcitonin, corticotrophin, or 5-HIAA, which is abbreviation of 5-hydroxyindole acetic acid can occur. And here screening is dependent on the radiological images, as no biochemical abnormalities have been consistently observed. Then pituitary tumors, you have to go for growth hormone levels, insulin like growth factor 1 and prolactin. And hyperparathyroidism, calcium is elevated with inappropriate elevated parathyroid hormone levels. Talking about imaging studies, here you see a sagittal. The left one is the sagittal and the right one is the coronal T1 weighted MRI of the brain, in which patients with multiple endocrine neoplasm syndrome type 1. These images shows pituitary macroadenoma. You can see easily arrows placed at the site of the lesion. Then comes the octreotide scan in a patient with multiple endocrine neoplasm type 1. These nuclear images demonstrate abnormal activity in the pituitary macroadenoma. Curved arrows you can see. Parathyroid adenoma, again straight arrows. Then the gastrinoma, metastasis throughout the abdomen. You can easily see the brightening in that areas. CT scan of the pancreas is in a patient with MEN1 and gastrinoma. The image shows pancreatic head mass, large white arrow showing especially that area, as well as low attenuating lesions in the liver. Small black arrows have been placed there. You can see easily. Here is the CT with oral and IV contrast in a patient with biochemical evidence of insulinoma. You see a 3 cm contrast enhancing nucleus as a tail of pancreas, which is posterior to the stomach. This is the endoscopic ultrasonogram in a patient with the insulinoma. The hypoechoic nucleus is seen in the body of the pancreas anterior to the splenic vein. This modality is not routinely used. Then comes the MEB scan in a patient with multiple endocrine neoplasm. These images demonstrate persistent abnormal activities of the inferior right parathyroid gland that is consistent with an adenoma. Here you see X-ray AP view of right hand in a patient of MEN1 and primary hyperparathyroidism. You see subperiosteal bone resorption along the radial aspects of the middle phalanges. What other tests we can have? A genetic testing and histological findings. Talking about hyperparathyroidisms, how will you approach? Surgery is the definite treatment. You will go for subtotal. It means that out of 4, 3.5 glands removed, or a total parathyroidectomy with a forearm auto transplantation is performed with an open bilateral neck exploration. The recommended timing of surgery in a patient is controversial. Recurrent hypercalcemia is common. Transcervical thymectomy may need to be performed at the same time owing to the mortality associated with the malignant carcinoid tumors of the thymus. For gastrinoma, you can inhibit hypersecretion by PPIs. Then histamine receptor antagonists may be added. Non-metastatic gastinomas located in the pancreas are rare but can be surgically excised. Removal of tumors larger than 2 cm in diameter reduces the frequency of liver metastasis, which is an important prognostic factor. Surgical cure of multiple duodenal gastinomas is difficult. Other novel approaches are there, such as chemotherapeutic agents or hormonal therapy with somatostatin analogs can be considered to treat disseminated gastinomas. For insulinoma, yes, surgical removal of the tumor is the treatment of choice. If it is unresectable, you can go for diazoxide or octreotide, chemotherapeutic agents, or hepatic artery embolization if there is a metastatic disease. Some authors recommend subtotal pancreatectomy in patients with multiple tumors or when the tumor is not localized. In subtotal, you will remove 80% or more of the pancreas. The rest will be there to work. Again, glucagonoma, surgical removal of the tumor is the treatment of choice. However, if it has metastasized, you can go for somatostatin analogs and chemoembolization of the hepatic artery. Then again, lipomas, you will start with the somatostatin analogs, controls symptoms in 80% of the cases, although surgical cure should be attempted. Asymptomatic non-functioning pancreatic neuroendocrine tumors, there is a consensus regarding surgical indications has not been established. The goal is to reduce mortality and morbidity associated with the metastatic disease while preserving pancreatic tissue. Conflicting expert opinions suggest surgical removal of the tumors greater than 1 cm versus 2 cm. Talking about pituitary tumors associated with MEN1, the treatment is similar to non-MEN1 associated pituitary tumors. Prolactinomas are treated with bromocriptine or cabergoline. Octreotide or lenalidomide is used for somatotrophinomas. Transsephinidal tumor removal with radiotherapy can be used if necessary. Carcinoid tumors, if resectable, you go for surgery. If unresectable, you can go for with radiotherapy or chemotherapy. Somatostatin analogs again can help, and symptoms may shrink some tumors as well. Cutaneous manifestations of MEN1, as we discussed, as management is conservative for lipomas, facial angiofibromas, and cholangiomas. Local oxygen can be performed if desired, or if the patient feels pain, or if there is a cosmetic issue. Now, a few words about the somatostatin analogs been routinely used in many of the secretory tumors. It has been used since 1980s. Hormone blocking agents that are synthetic somatostatin derivatives, octreotide, lenalidomide. Octreotide acts primarily on somatostatin receptors subtype 2 and 5. It inhibits growth hormone secretion and has multitude of other endocrine and non-endocrine effects, including inhibition of glucagon, vasoactive intestinal peptide, and GI peptides. Talking about side effects, development of gallstones, yes, can due to inhibition of the cholecystokinin release, pain at the site, hyper or hyperglycemia, rash, alopecia, and fluid retention can be there. So this diagram some have predictive effects of somatostatin analogs. Starting from the liver, reduced liver blood flow, then it inhibits gallstone contractility and bile flow. Then comes the inhibition of GI and pancreatic peptide hormone secretion, then reduced plankning blood flow. It also inhibits gastric acid and pepsin secretion, inhibits pancreatic sucrine secretion, slows gastrointestinal transit time, and inhibits absorption of glucose and amino acids. It also stimulates water and electrolyte absorption and inhibits the tissue growth and proliferation. I have specially added this slide because somatostatin analogs are been routinely used in patients of liver disease in the wards. Preferably, you must be aware of the effects of the somatostatin analogs. Then type 2. It is also called Sippel syndrome because Sippel first described it in 1961. The thyroid cancer found with pheochromocytoma was discovered in 1965 to be a medullary carcinoma characterized by stromal amyloid. In 1968, the familial constellation of the pathology in conjunction with parathyroid hyperplasia was recognized as MEN2. Before that, it was not term was not been used, and the distinction between MEN2A and MEN2B was not made until 1975. So phenotypes meant to A patient do not have the phenotypic abnormalities of the mucosal neuromas and marfanoid habitus found in meant to B patients. Medullary thyroid carcinoma meant to A patients have a less virulent than do meant to B patients. Parathyroid hyperplasia again meant to A patients may have, which is exceedingly rare in meant to B. A third type of meant to is familial medullary thyroid carcinoma. Only FMTC is an abbreviation used for this. Talking about MEN2 is a rare familial cancer syndrome caused by the mutation in the ret proto-onco gene localized to 10q12.2, inherited as an autosomal dominant disorder. Talking about medullary thyroid carcinoma, it is virtually in all patients with MEN2A. The first expression abnormality and usually occurs in the second or third decade of life. Typically bilateral multicentric in contrast to sporadic medullary thyroid carcinomas, which is unilateral. Then comes talking about the pheochromocytoma. We will discuss this malignancy in the separate lecture. It is about 50% of patients with MEN2A have pheochromocytoma. It's usually bilateral, 60 to 80% of patients. And compared with the 10% of patients with sporadic pheochromocytomas, usually it is diagnosed at the same time as the medullary thyroid carcinoma or several years later, with both occurring primarily in the second or third decade. Nearly all are benign. Even so, these lesions can cause a life-threatening hypertensive episodes or arrhythmias because of excessive catecholamine release. Then comes the parathyroid hyperplasia. Nearly half of the patients with MEN2A but are less common than pheochromocytoma, and also it can be clinically silent as well. We can have hypertension if pheochromocytoma develops. These increases can be chronic or episodic. Some patients have episodes of sweating and headache. We can have diarrhea if a patient has medullary thyroid carcinoma. This may be related to elevated prostaglandins or calcitonin levels. Then pruritic skin lesions. Cutaneous lichen amyloidosis in MEN2A patients manifests as multiple pruritic hyperpigmented lichenoid papules in the scapular area of the back. Here you see. Marfanoid habitus of high arched palate, pectus excavatum, bilateral pes cavus, and scoliosis are observed in MEN2B patients. Neuromas on the eyelids, conjunctiva, nasal and laryngeal mucosa, tongue and lips are frequent findings. Patients also have prominent hypertrophied lips leading to the characteristic facies. Localized pruritus appears of the upper back in MEN2B patients as well. Here you see the marfanoid features. Talking about is how we will approach to MEN2B A at the same time. You will perform genetic screening for RET mutation in all index patients. If a mutation is identified, then you will go for screen the family members who are at the risk. Baseline calcitonin levels and serum calcium and PDH levels along with urine collection of catecholamine and metanephrine concentration to diagnose other tumors associated with MEN2. Talking about imaging studies, you can perform CT, MRI or MIBG scan for localization of the tumors. Yes, FNAC, the fine needle aspiration, you usually avoid the removal of cells from thyroid masses for cytology in patients with MEN2 who have had their diagnosis previously confirmed by either genetic analysis or elevated calcitonin levels, as biopsy increases the possibility of tumor spread. Usually we avoid it until it has a very compelling indication and we are unable to make a diagnosis. How we will manage? Talking about pheochromocytoma, usually we have to operate it, and perioperatively you have to go for alpha blocker or tyrosine hydroxylase inhibitors such as metyrosine for 1 to 2 weeks. After which you have to add on, after 1 to 2 weeks, you have to add on beta blockers to avoid the reflux effects of the alpha blockers, especially the reflex tachycardia. Talking about hypercalcemia, patients present with severe hypercalcemia should first be hydrated, often which they should be treated with furosemide. If they remain severely hypercalcemic, consider treatment with calcitonin, glucocorticoids, or bisphosphonates such as pamidronate. Surgical treatment is the standard with replacement therapy after the surgery. Patients require hormone replacement therapy following total thyroidectomy and bilateral adrenalectomy or when they have post-operative hypoparathyroidism. In addition, patients who develop post-operative hypoparathyroidism needs supplemented calcium and vitamin D. The corticosteroid cortisone and the mineral corticoid fludrocortisone acetate can be used in combination in patients suffering from adrenocortical insufficiency after the surgery. This diagram again is to remember. We talked earlier about what type of tumors are present in men 1, men 2. Men 1 is also called as Wermer syndrome, men 2 is called Sippel syndrome, and the diagrams are made to remember as you see, and meant to be the morphonoid features as well been included. Now we are moving to the next topic, that is the autoimmune polyglandular syndrome. There are many synonyms of this autoimmune polyglandular syndrome which have been described on this slide. So what is actually autoimmune polyglandular syndrome is? By definition, is a heterogeneous group of uncommon disease characterized by autoimmune activity against more than one organ. The organs may be endocrine or non-endocrine. The autoimmune polyglandular syndrome results from a loss of tolerance to the self-antigens. Here is the classification. You see there are 4 types of APS. And in APS 1 you have chronic candidiasis, chronic hypoparathyroidism, Addison's disease. So at least 2 must be present to label it as APS 1. In APS 2 you see Addison's disease, which is usually always present, or autoimmune thyroid disease and or type 1 diabetes mellitus. In APS 3 you have to add on autoimmune thyroid disease associated with other autoimmune diseases excluding Addison's disease or hypoparathyroidism, which are present in the previous 2 types. Combination not included in the previous groups are labeled as APS type 4. So APS 1. So this condition is also termed as APECED, APECED, autoimmune polyendocrine candidiasis ectodermal dystrophy. So by remembering only this line, you can describe what is present to be labeled as APS 1. It is also called Whitaker syndrome. Due to the monogenetic mutations, males and females are usually equally affected. Talking about the epidemiology, the disease is not very common. The highest prevalence has been found in certain populations with a high degree of consanguinity: Iranian Jews, Finland, Sardinia, and Norway. It is autosomal recessive disease. It is linked to the mutation of the AIRE gene, which is the autoimmune regulator gene. It is located in chromosome 21q 22.3. So what this gene expressed mainly in the thymus, and the expressed in the medullary thymic epithelial cells as well, but also in lymph nodes, liver, pancreas, adrenal cortex, and testis as well. More than 70 different mutations in the AIRE gene have been now reported. Mutations can be confirmed in more than 95% of patients with the clinical diagnosis of APS 1. We have discussed about the prevalence. Then several hypotheses have been put forward to explain how an individual can lose its tolerance against self-antigens, the release of sequestered antigens, the environmental induced alterations of the host membrane proteins, or there is a cross reactivity between the environmental agents and the host agents, or there is a defect in the cell regulation in the immune response. Also, hypothesis is that the organs derived from a same germ layer can express common germ layer specific antigens that could serve as the targets for the autoimmune responses in APS. It has been suggested that APS may be due to external agents sharing one or more epitopes with a common antigen in several endocrine tissues. So this diagram shows that genes, genetic factors, environmental factors, and immune regulations all combine to make the autoimmune disease to occur. It has been hypothesized that mutations of the A gene cause loss of peripheral antigen expression in the thymus and probably decreased deletion of the autoreactive T lymphocytes that target such peripheral antigens. AERE gene function is usually to expression of tissue specific antigen, which is called self antigen to thymocytes, which leads to self tolerance by eliminating of the autoreactive T cells. How we diagnose? Clinically diagnosis requires the presence of two from three major criteria. Whitaker's triads. Number one is the mucocutaneous candidiasis, number two is the hypoparathyroidism, and number three is the adenocortical insufficiency or autoantibodies against 21 hydroxylase. Or if a sibling has the syndrome, only one major is required. And the diagnosis could be made by the molecular genetics in presence of the minors. And the different genotypes lead to different phenotypes, and the different genotypes can lead to same phenotypes, which is called overlapping. One genotype can lead to different phenotypes as well. So there is a diversity in the presentation. Patients begin with usually with CMC followed by hypoparathyroidism and finally by Addison's. So as we have discussed in the previous slides, first there is a mucocutaneous candidiasis followed by hypoparathyroidism and finally Addison's. That makes a classical presentation of APS 1. It has been observed that the earlier was the first clinical presentation, the greater will be the number of diseases that will develop during the life of patients with APS 1. Chronic mucocutaneous candidiasis is often the first condition detected. The onset is usually before 5 years of age, first sign of APS in 60% of patients, and by the age of 40 of age, 100% patients of the patients with APS will develop candidiasis. Etiology it is due to the selective immunological deficiency of T cells towards Candida albicans. Humoral immunity B cell function is normal. Anticytokines, autoantibodies against the thymocyte 17 related cytokines that are interleukin 22, interleukin 17A, and interleukin 17F were implicated. Usually presents with oral thrush, diaper rash, vulvovaginal candidiasis at puberty in females, nail infection leading to the darkened discoloration, thickening or erosions, intestinal mucosal candidiasis leading to intermittent abdominal pain and diarrhea. Retrosternal pain occurring in patients with a confirmed oral candidiasis, just esophageal candidiasis, which may lead to stricture and dysphagia. Epithelial carcinoma of the oral mucosa, tongue, or esophagus with its high mortality is well described in APS 1 patients with chronic mucocutaneous or mucosal candidiasis. Here you see oral candidiasis, oral thrush. You see the involvement of the nails. Here it is a closer view, and you see the endoscopic view showing the esophageal candidiasis. Talking about the chronic hypoparathyroidism, usually presents before puberty, and atrophy and infiltration of the parathyroid gland with the mononuclear cells have been found on biopsy. The clinical patients may have presented with paresthesias, hyperexcitability, hypotension, carbopetal spasm, laryngospasm, and generalized seizures. These symptoms may, however, be masked in the presence of the adrenal insufficiency if it is present at the same time. Here you see the normal calcifications in the CT brain in a patient with chronic hypoparathyroidism. Again, hypocalcemia, hyperphosphatemia with a low PTH is a diagnostic of chronic hypoparathyroidism. Recently, patients with APS1 and hypoparathyroidism, autoantibodies against calcium sensing receptors and other autoantibodies have been reported. Antibodies against NLP5 have been found in 49% of patients with APS1. Now coming to the third one, a part of APS is the Addison's disease, the found in more than 85% of APS1 patients. Adrenocortical failure usually has its peak onset before adolescence, showed atrophy of the glands and lymphocyte infiltration on the histopathology. This is the deficiencies of the cortisol, aldosterone, and adrenal androgens may present simultaneously or may evolve over months to several years. Clinical presentation is usually the initial presentation, often is non-specific. These include fatigue, weight loss, myalgias, arthralgias, behavioral changes, nausea, vomiting, abdominal pain, weight loss, and diarrhea. Hyperpigmentation and postural hypotension. Then adrenal crisis with hyponatremia, hyperkalemia, and hypoglycemia may be there. Here are some minor associations of APS1. You can see that gonadal failure, thyroiditis, autoimmune hepatitis, diabetes type 1, cholelithiasis, and many of the enlisted minor diseases which are associated APS1. Here you see alopecia baldness. Alopecia totalis is also been associated with APS1. And a few words about the gonadal failure. It is usually a hypergonadotrophic hypogonadism. It's more common in females. 50% of patients with APS develop ovarian failure by the age of 20 years of age. In most cases, presents usually as a secondary amenorrhea, although in some cases primary amenorrhea may be present. Also, menstrual irregularities. Patient may have a polycystic ovaries or infertility. Less than 30% of men with APS1 develop testicular failure. 60 to 80% of patients with APS1 steroid-producing cell antibodies have been detected. Autoimmune thyroid disease occurs in 4 to 36% of the cases between 9 to 32 years of age, called chronic thyroiditis. Antimicrosomal, antiperoxidase, or antithyroglobulin antibodies are detected in most patients with autoimmune thyroid disease. Autoimmune hepatitis, yes, it occurs 10% to 31% of APS1, usually subclinical to fulminant hepatic failure, and the leading cause of death in these patients is the autoimmune hepatitis. All patients suspected of having APS1 should have their liver function tests regularly monitored. Autoimmune hepatitis in APS1 correlated with the positive antibodies against liver kidney microsomes, which is also called as anti-LKM antibodies. Anti-LKM antibodies are present even in 25% without alterations in their liver function tests. Then malabsorption is also associated with APS1. How we will manage APS1? Specific organ autoantibodies screening, then genetic study plus general antibodies studies, then assessment of the endocrine function. In hypothyroidism, patients with confirmed APS, evidence for adrenal autoimmunity must also be sought out. before starting thyroid hormone replacement therapy. Usually, sudden hypercalcemia in hypoparathyroidism individuals may signal the beginning of the adrenal insufficiency indirectly. Then any patient with APS1 should be seen and screened for autoantibodies at 6 months interval regularly. Then anti-interferon and alpha and delta studies show that up to 100% of patients with APS1 have been found to express autoantibodies reacting with interferon omega. Also, the great majority express autoantibodies reacting with interferon alpha. Their role in pathogenesis is still controversial. Then search for autoantibodies against interferon gamma alpha enables proof of exclusion of APECED with more certainty than gene analysis. It is highly specific and sensitive for APECD if thymoma and myasthenia gravis are excluded, and its presence early in the course of the disease and persists for years. So any patient with suspected APS should be screened with a panel of autoantibodies. Then type 1 interferons autoantibodies, omega and alpha, adrenal cortex cytoplasmic autoantibodies, 21 hydroxylase autoantibodies, GADA and IA, 1A, 2A and 1AA, ZNT8 and ICA, thyroid microsomal and thyroperoxidase antibodies, thyroglobulin autoantibodies, steroid cell autoantibodies, anti-LKM antibodies, then endomyocyl transglutaminase antibodies, autoantibodies to rule out malabsorption, intrinsic factor antibodies. Then you can have a hydrogen potassium ATPase autoantibodies, partial parietal cell autoantibodies, and autoantibodies against tyrosine kinase hydroxylase and the complement fixing melanocyte antibodies. So this is a list of autoantibodies. If you suspect a patient is having APS, you should go for all these autoantibody screening. So here is the APCD manifests and associated autoantibodies. Each disease have been narrated with their specific autoantibodies to be tested. Then how we will assess the end organ function? Assessment of the end organ function in any patient with autoantibodies is recommended. We will investigate with the early morning cortisol levels, electrolytes, sodium, potassium, renins, fasting blood glucose testing, calcium, phosphate and PTH, TSH levels, free thyroid hormone levels, T4, T3, FSH, LH levels, testosterone, estradiol levels, hemoglobin and hematocrit, mean corpuscular volume, vitamin B12 levels and liver function tests. How we will treat? For candidiasis, you will go for antifungal. Aggressive therapy of oral is indicated in order to prevent the late complication of epithelial carcinoma. Fluconazole is preferred over ketoconazole. Hypoparathyroidism, you can give calcium and 1-alpha. For Addison's, hydrocortisone or prednisolone, you can offer fludrocortisone as well. For hypothyroidism, levothyroxine, as you know. For hypergonadotrophic hypogonadism, testosterone in male and estrogen and progesterone in female. Asplenia, you should vaccinate. Prophylactic antibiotics can be given. Autoimmune hepatitis, immunosuppressant. Keratoconjunctivitis, you will go for immunosuppressant. Malabsorption syndrome, you will go for immunosuppressant. Pure red cell aplasia, you will go for immunosuppressants. Talking about APS2 is the most common autoimmune polyglandular syndrome. Its incidence is 1 into 20,000, more in females, particularly during the third or fourth decade. The precise etiology is not known. These cases occur sporadically or within families. Inheritance of APS2 is complex. Within some families, it appears to be inherited as an autosomal dominant, and genes on chromosome 6 playing a predominant role, and this chromosome contains the major histocompatibility loci. Then patients with APS2 have HLA associations as well as, and those with type 1 diabetes. Primary association APS2 appears to be with the class 2 HLA alleles DR3, DQ2 and DR4 and DQ8. Primary adrenal insufficiency in type 2 but not in type 1 APS is strongly associated with both HLA DR3 and HLA DR4. Then how we will diagnose is defined by the coexistence of autoimmune adrenal insufficiency or serological evidence of adrenalitis with one of the following, either autoimmune thyroiditis or serological evidence of thyroid autoantibodies, or type 1 diabetes mellitus or islet and autoimmunity. Schmidt syndrome, if there is adrenal cortical insufficiency along with autoimmune thyroiditis, it is called Schmidt syndrome. Carpenter syndrome, if Schmidt syndrome is associated with type 1 diabetes, we call it as Carpenter syndrome. Usually, presentation is with adrenocortical failure in the initial presentation, 50% of cases of APS2. Then comes the autoimmune thyroid disease, coexistence with 80 to 18 to 90% of the females, and the Addison disease. The type 1 diabetes coexists nearly 50% of the patients with Addison's disease. There are many other diseases with APS2. And IPEX, we have few words in the next slide about the IPEX. Then the thymic tumors, which is also other autoimmune polyglandular disease syndromes. Then we have few words about IPEX. IPEX is the immune dysfunction, polyendocrinopathy and enteropathy, which is X-linked. This is also called X-linked. It is X-linked autoimmunity and allergic dysregulation. So here we have a X-linked recessive disease due to the absence of the normal FOXP3 expression. It's a neonatal onset type 1 diabetes, dermatitis, enteropathies, thyroiditis, hemolytic anemia, and thrombocytopenia. Usually we go for long-term immunosuppression or bone marrow transplantation appears to be the only effective therapy for IPEX. So here are some characteristics of autoimmune polyglandular syndromes, which are most common and less common, so the APS1 and APS2 and IPEX, as we have also discussed them separately